And thanks, Eric, for the very quick briefing. And hi, very good afternoon to Prof. Chi, Dr. Ali, Dr. Effa, Dr. Shatish, and Dr. Zarina, and to all the participants. And this is Wingzi here from the Heart Failure Medical Team of Novartis, Malaysia. And it's a great pleasure today to have the HF 360 Approach series, in which we'll be having 4 distinguished speakers today, and also a renowned chairperson to share with us on a very practical topic today, with the focus theme on acute heart failure. And it's our great honor today to have Dr. Chi Kok Han, the Senior Consultant Cardiologist from UMMC, to be with us today to chair the session. And I guess Prof. Chi needs no further introduction, as we do really see him very, very often in various platforms. And without further ado, probably I'll pass the floor to Prof. Chi to kickstart the session for today.
Hi, good afternoon, everyone. So first of all, welcome to the webinar series. I think today's webinar series is slightly different from what we have done. I think previously we all focused on chronic heart failure, but today we want to focus on acute heart failure. I think this is still a very common problem, and in fact, this is to us is actually who work in cardiology or even in internal medicine is a day-to-day challenge. How do we actually going to manage acute heart failure? So today we will have 2 sessions. The first session are looking at a general overview of acute decompensated heart failure, and the second session are actually looking into diuretic resistance. So to start with is actually will be our Dr. Zarina Banu binti Abdullah. He's currently the clinical cardiologist from Hospital Pulau Pinang, and she have actually keen interest in cardiac imaging, which actually will be actually sharing with us a case of acute decompensated heart failure. And then after that, I would like to invite Dr. Muhammad Ali in Abdul Kader. He is currently the head of intervention lab in Hospital Pulau Pinang, and he will give us an overview of the practical aspect of acute decompensated heart failure, especially looking into our own Malaysian guideline. So without much further ado, I would like to pass over to Dr. Zarina, who will share a case of how she managed the acute heart failure. Dr. Zarina, please.
Thank you very much, Prof. Assalamualaikum and good afternoon. I'll be presenting a case of acute heart failure. This is let me start my slideshows. Okay, this is Mr. OPP is a 53 years old gentleman, chronic smoker for more than 30 years. He was newly diagnosed as ischemic dilated cardiomyopathy with poor LV function and presented to private hospital on the 9th of June with shortness of breath and bilateral leg swelling. 3 days later, coronary angiogram done at private hospital shows a proximal LAD 100% stenosis. The right coronaries and the left circumflex artery were normal. I don't have the CNE with me, so I only managed to capture the, this is the angiogram report done in private. Echo done over there shows a dilated all chambers with a poor LV function, EF of 23%, local hypokinesia with LV apical aneurysm. Cardiac MR done shows a full thickness scarring of anterior and lateral wall of LV at cardiac apex, partial thickness scarring at anterior wall, and the heart was grossly enlarged with the EF 17% in cardiac MR. And they also did the ultrasound of lower limb, which shows no evidence of deep vein thrombosis, and the patient was discharged on 14th of June with spironolactone 25 mg and furosemide, oral furosemide 40 mg/d. They actually give him allopurinol because patient's uric acid was high at that point of time. And the next day, he presented to us on the 15th of June with chest tightness and shortness of breath since discharge. He also complained of autopnea, paroxysmal nocturnal dyspnea for the last 1 year with bilateral leg swelling up to the knee. The initial ABG done at emergency department shows type 1 respiratory failure with metabolic acidosis, and the SpO2 was only 88.2%. And the patient was conscious but tachypneic, so the patient was initially put on CPAP, and later was downgraded to angioedema 60%. The peripheries were cold and the blood pressure was lowish with a BP of 84/52, and then immediately started on IVI noradrenaline, and he was a bit tachycardic, otherwise febrile, and the patient has a bilateral crepitation up to mid-zone with a bilateral pedal edema. The JVP was raised. And this is the chest X-ray. If you can see, it is gross. You can see a gross cardiomegaly with upper lobe diversion, and you can see the curly B lines and minimal pleural effusion. Okay, I don't have the ECG done on the day of admission at emergency department. It is already faded, and I managed to get this ECG, which was done on the next day. At that point of time, the heart rate was not tachycardia anymore. Patient was well controlled rate, and the ECG shows the sinus rhythm with poor R-wave progressions in anterior leads. However, there's no acute ischemic changes. Okay, this is echo done by us. This is a parasternal long axis. If you can see, there is a global hypokinesia and dilated chambers. The RVOT is dilated. This is the still picture of M mode showing the parameters and of diastolic for the aortic root, and if you can see, the LE is severely dilated. And this is the still picture of M mode for the LV function measurement. If you can see, the LV ID also here is dilated, and the EF by M mode is 16.5%. This is our short axis view. The LV, as you can see here, is D-shaped, and the RV is enlarged and compressing the LV. This is this is another echo view, four-chamber view. It shows all the chambers are dilated, and you can see the RV contraction as actually more than the LV contraction. If you can see by eyeballing, the mitral valve and the tricuspid valve is the same level. It shows the RV is enlarged, and there's a global hypokinesia, and there is a dyskinesia at the apex, LV apex. This three-chamber view is actually meant to visualize the apex well. As you know, these patients having a very poor LV function, EF is only 15% and a very high risk to develop LV clot. And so that's the reason we want to have the three-chamber view here to visualize the apex better, and there is the apex, shows the dyskinesia. This is another view, two-chamber view, shows the inferior and anterior wall is hypokinesia. And this is the still picture showing an impaired RV systolic function via the TAPSE parameter. If you can see, the TAPSE is only 1.65 centimeter. This is the still picture showing LV and diastolic volume. It is markedly raised. If you can see here, it's 372 mils. Anything more than 80 is severely diluted by volume. And this is the end stage, LV end stage systolic volume, which is 316. Volume is 317 mil, and it is severely dilated. And this is the Simpson single plane method used to calculate the LVEF. Via this method, we got the EF of 15.1%. And this is my last echo picture. Shows the IV C diameter by M mode is dilated. Is 2.69 centimeter, and it is stiff and not collapsible. Okay, this is a summary of our echo, and later the patient had one ABG done under venturi mask. There shows some improvement, pH of 7.3, and the saturation actually improved to 96.2%. And the initial blood test done at emergency department, the renal profile. Sodium is 134, potassium was 3.6, urea 5.5, and the creatinine was 118. We have no baseline of the patient, and the cardiac enzyme was not raised. CKMB is only 2.42. The uric acid high, and the NT-proBNP is severely elevated. It's 5,000 plus. Urine FAME done or shows normal. This is our investigation chart. If you can see, the hemoglobin is raised. This is secondary polycythemia due to the chronic smoker. Total white was not raised, platelet normal, and the patient fasting sugar was 6.9. Cardiac enzyme not raised. His cholesterol is raised with the LDL of 3.4 and TG of 2.0. And again, you can see the serial renal profile and the repeated cardiac enzyme, which was normal. So at this point of time, what is your diagnosis? So if you can see, according to our Malaysian CPG Management of Heart Failure, 4th edition 2019, we can classify into 4 groups, which is warm, wet, warm, dry, cool, wet, and cold, dry. And which category do you think our patient falls to? It's definitely this one, cold and wet, whereby you can, as you know, our patient is poor and the patient having a pulmonary congestion and the blood pressure low, supported by IV noradrenaline. And this is another algorithm for the diagnosis of acute heart failure. If you see, whenever we see a patient presented with signs and symptoms on heart failure, first of all, we have to do the ECG and see whether the patient got any ischemic changes and look at the chest radiograph for failure and also assess the cardiomegaly. And if it is available, we can do a natriuretic peptide to see the level. If the test is normal, we can easily find out the, rule out the heart failure dysfunction. If it is a test is abnormal, then you have to proceed with echo. And if it is abnormal, and we can actually determine the underlying cause of the heart failure, and we can actually type the patient into the reduced heart failure, reduced EF, preserved EF, or mid-range EF, and treat the patient accordingly. So for our patient, the diagnosis is acute decompensated heart failure with underlying ischemic dilated cardiomyopathy with poor LV function in cardiogenic shock. So what do you do next? How would you like to manage this patient? We go to our CPG guideline again. If you can see here for the cold and wet, first of all, you have to check the blood pressure and see whether it's a systolic is more than 100 or less than 100. If it is more, you can immediately start the diuretics. If it is less, as our patient, we started on IV noradrenaline to bring up the blood pressure to more than 100. And if it is not improved, you can increase the inotropic support and add on dopamine as to improve the renal perfusion. So for us, our patient, after starting of IV noradrenaline, we managed to increase the systolic blood pressure more than 100, started on diuretics, and the patient improved, and later we actually oralized the medication. Okay, this is the recommendation of management. First and foremost, the initial management will be oxygen, diuretics, nitrates, and morphine. If it is not responsive and the systolic more than 100, then you can move on to diuretics and also dopamine to improve the renal perfusions. And then if the patient does not respond to the initial treatment and the blood pressure is lowish, then you'll be thinking about adding on noradrenaline or dopamine. And if it is even worse, then you're probably thinking of putting IABP and ventricular assist device. So for our patient, we actually started on IVI noradrenaline 0.5 mics and titrate accordingly, and we managed to bring up the blood pressure more than 100, and we started on IVI furosemide infusion 8 milligram per hour, and we titrate accordingly. And we also started the patient on cardifrine due to the underlying coronary artery disease and also atorvastatin, then followed by the fluid restriction and strict IO charting. Okay, this is our patient's progress from the day of admission up to day 3. If you can see, the urine output was ranging about 1.8 liter to 2.5 liter a day, and within these 3 days, we managed to wean off the inotropic support, and also the patient's failure symptoms was improving, and we managed to change from infusion to boluses of IV furosemide, and we do add on spironolactone. At that point of time, the patient's lung was having a bivessel crepitation and the pedal edema was resolving. Okay, this is the progress at day 4 and day 5. The urine output was about 1 liter to 1.2 liter, and the patient's failure symptoms actually resolved, and the lungs was clear and only very minimal pedal edema. We then changed the IV furosemide to oral furosemide. We managed to increase the spironolactone to 25 milligram daily, and we started on a small dose of bisoprolol and Entresto. And we also enrolled this patient in our cardiac rehabilitation program. We have a very good and a very dedicated heart failure and cardiac rehab team in our center. This is the investigation chart. This is the investigation chart that I have shown you again. If you can see here, there is you can see the creatinine level from the day of admission up to discharge, and also the second full blood count shows no evidence of infection, and also the cardiac enzyme was normal. And our patient was discharged well on 19, and this is the medication upon discharge. The Entresto was 25 milligram and followed by furosemide 40 and spironolactone 25 milligram. And we also do refer this patient for quit smoking clinic and to repeat cardiac MRI as outpatient, and given a DCA to our heart failure clinic and cardiac rehabilitation. So when we manage a patient, the non-pharmacological measures is very important. Basically, the education is very important. We have to educate the patient about what is the do and don'ts in taking care of themselves, about fluid restrictions, compliance to the medication. We also have a so-called modified gym in our center for our heart failure patients, and we also have a good dietitian who can come and advise about the diet and nutrition, and also the lifestyle measures. We also give pneumococcal vaccination for our patient more than 60 years old. And this is a patient's progress in our first heart failure clinic review a month later. That was on 9th of July, and the patient improved. The effort tolerance improved to functional class 1 to 2, and the blood pressure was holding well, and the lungs is clear, no pedal edema. So we increased the Entresto to 50 milligram and reduced the furosemide to 40 milligram daily, and we continue with other medication. This is our second review in October. There's a marked reduction in the effort tolerance. Patient functional class was 1, and the blood pressure was holding on well, and the lungs was clear. We managed to increase the Entresto to 100 milligram BD, and furosemide was still on daily dose. This is our cardiac MRI done 4 months later after the treatment. The patient, remember, the patient was admitted in June, and this was done on 16th of October. And there is a slide, if you can see the, probably I have increased this to you to have a clear view. If you can see here, there's a slight improvement of the LV function. If you can remember, the earlier on was 17%, which was done in private, and now it's about 23.6%. And this cardiac MR shows 6 out of 17 segment, and this is purely from the anterior territory, which is not viable. Okay, we also do have a 6-minute walk test. I have 3 readings for this patient, which was done in our heart failure clinic. This is the first heart clinic review, the SpO2 pre and post, and then the heart rate before the patient go for the 6-minute walk test. And this RPE actually defined as the rate of perceived exertion, and the scale range from 6 to 20. 6 is basically no symptoms at all, and 20 is the maximal symptomatic during exertion. So if you can see here, the first 6-minute walk test, the patient able to walk for 290 meter, max of 2.4, and the RPE baseline already got a bit of symptoms, and post 6-minute walk test patient was actually having heavy exertion symptoms. And the second one, SpO2 was quite good, and the pre was basically very minimal, and post is a dramatic changes, if you can see here. And the patient able to walk up to 440 meter. And our third review shows increment in the distance to 480 with a baseline of RPE of 6. Basically, patient was asymptomatic, and a slight exertion tiredness after the 6-minute walk test, and they're able to achieve a max of 3.5. Okay, this is the investigation chart showing upon discharge and during our follow-up. If you can see here, I also add on the dosage of Entresto. When we review the patient during first review, the creatinine actually slight improvement despite on Entresto, and the potassium around 4.5. So the patient on spironolactone, and we didn't give any potassium supplement when the patient on furosemide. And if you can see the second review, there's an improvement of the creatinine, and we managed to increase the Entresto to 50 milligram BD, and the creatinine level was holding on to 100. The Entresto to 100 milligram BD. Despite the 100 milligram BD, the potassium was still holding on about 4. and there is a marked improvement in his cholesterol level, LDL from 3.4 down to 1.4, and the TG was only 1.3. Okay, this is the patient's progress during our third heart failure clinic review on November. Patient's effort tolerance improved, functional class 1, BP was holding on well, lungs clear. And if you can see here, the pro-BNP, there's a marked improvement, about 600 plus from the initial one, which was 5,000 plus. And we are seeing the patient in our heart failure clinic every 3 months. And during our third review, we managed to increase the blood pressure to 5 milligram daily and continue with the rest of the medication. And the last review was in January this year, and the patient is supposed to come to and see us somewhere in April. And currently, because the patient was working in Klang Valley, and because of the MCO, there's a delay. But anyway, we do contact the patient via phone and was asking about his symptoms, and we post all the medication to him, and he'll be coming and seeing us next week for a repeat echo. I think with that, thank you. So where do I go? Go to him.
Thank you very much, Dr. Zarina, for your sharing. So with that, I would like to invite Dr. Ali, where he'll be sharing with us on the practical aspects on AHF management. Dr. Ali, the floor is yours. Thank you.
Right, thank you very much, Dan. Okay, thank you very much, Novartis, for the kind introduction and as well as invitation to organize this particular event. So it's a very important event that we know the heart failure is one of the critical area that in a non-communicable disease that we are encountering more and more now, and is one of the prime cause for the death, for the hospitalization as well as the death in Malaysia. So basically, it all boils down from the acute heart failure. Let me see how can I show this. Okay, so what I'm going to touch is basically my topic today is an acute heart failure, practical aspect of acute heart failure management. So these are the 5 principles that you need to be aware of when you're treating the heart failure. First is the rapid recognition. First is the rapid recognition. Sorry then. First is the rapid recognition of the condition. Then number 2 is the hemodynamic status that you need to identify as well, you need to address and need to stabilize the condition. Number 3 is the oxygenation. This is very critical. Anyone is less than 95%, you need to optimize the oxygenation. But if they are more than 95%, obviously giving extra oxygen actually is not good. It may cause a vasoconstriction as well as it lead to LV depression. So you need to know the appropriate oxygen level and then treating that. Number 3, obviously the perfusion is very, very important, so that the vital organ perfusion need to be maintained by the blood pressure, and you need to look at the clinical symptoms and sign and need to relieve that. And last and not least is the cause. We need to identify the cause and need to address appropriately so that you will elevate the cause. You need to prevent from further aggravate the heart failure condition. So the classification, there's 2 ways you can classify. One is through the causality itself, whether is it the ischemic cause for heart failure, is it valvular heart disease, or is it sepsis related. So you can go by the cause itself, you can address that. Another way of classifying the acute heart failure, this is our Malaysian Heart Failure Guideline 2019. The 4th edition is introduced the 4 concepts. So when it came into the show, I was like looking at the classical temporal, the temperamental, the humoral theory. We have a warm, wet, cold, and dry. These are the old, the Avicennan concept of the traditional medicine. But we also can embrace into the modern heart failure, but it's a slightly nuanced way of explaining what does it mean. Okay, I go through each segment of it when you have a warm and wet, warm and dry, cold and wet, as well as the cold and dry. So basically, when you're looking at whether the patient is congestion, all right, the patient has a fluid overload, filling up his lungs, and then you look at the patient presenting to you with shortness of breath and a PND with orthopnea, you clinically examine him, you have a lung crepitation, JVP raised, hepatojugular reflux with pedal edema. So all that are the signs of congestion. We have a wet patient as compared to somebody who are dry, dehydrated, or non-congested. Number two, you're looking for the perfusion, sign of hypoperfusion, such as patients low blood pressure, cold peripheries, capillary refill time is more than 2 seconds, and then they have oliguria, dizziness, near syncopal. So all these signs of hypoperfusion, we need to determine. So that's first and foremost. This is how you classify. So once the patient, you determine patient acute heart failure, you need to look at the oxygenation, put the pulse oximeter. You need to look whether pulse oximeter less than 95%. So you need to address the oxygen. Then you classify the patient fall into which group, either warm wet, cold dry, or warm dry. Right, this is a busy slide. Is by looking at the 4 categories, you goes down to the level by level what need to be done. The key points after that is actually the blood pressure. No worry, I go one by one. The first component is the cold and wet, right? When the patient cold, meaning the patient is having a hypoperfusion, right? The patient is having hypoperfusion. At the same time, the patient also wet, they have a congested. So what you basically have to look for, you need to evaluate the patient's blood pressure, and then you see whether the blood pressure is, if they're less than 100, so remember the magic number 100, systolic blood pressure. If they are in a cold patient, when they're hypoperfusion, you need to bring up the blood pressure. The key point is the blood pressure first. Bring up, you use the very strongest inotrope, which is the noradrenaline. Then you slowly uptitrate. If it's very profound hypertension, you sometimes need to combine with the two, noradrenaline as well as dopamine. Otherwise, you start noradrenaline first. Evaluate the patient, is systolic blood pressure. Then if it's more than 100, now the patient is wet, you need to add the diuretics, IV diuretics. Then you go down whether the patient improve or not. If they are not improving, systolic blood pressure is still good, you may combine with vasodilator such as nitrate. Then you evaluate clinically whether the patient is improving. If still not improving, you can change the diuretic from bolus doses to continuous infusion, or you can combine with thiazide diuretics. You have a synergistic effect. You also can use the nitrates as a vasodilator. You also may combine with a low dose dopamine. Then you continuously evaluate the patient for the further improvement. Now comes to the cold and dry group. Just now we addressed the cold and wet. Now we go into cold and dry, where the patient is having a hypoperfusion, however, is not congested. So hypoperfusion is basically the most important is the blood pressure, as I told you. Whether you evaluate the patient is the hypotension, and the patient, because they are dry, they are not congested, you are liberal of challenging the fluid. You can give 100 to 200 cc. You can liberally challenge with the patient, and you also closely observe whether the patient go into a fluid overload. You don't aggressively give like 1-2 liter, get into trouble. They convert the patient from dry into wet then. So cautiously give, at the same time evaluate the blood pressure, right? If the blood pressure after you fluid challenge is still not improving, less than 100, now it comes to the inotropic support. You bring up the inotropes and then try to attain more than 100. If it's still not working, you need to look for what are the possible causes. Whether the patient is having significant hypoxemia, by this time you should having an ABG. If the PaO2 less than 60 or PCO2 is more than 50 millimeter mercury, whether the patient is acidosis. So these are the things that we need to correct. Need to institute appropriate ventilatory support. You can use high flow cannulation. Doesn't work, you go to non-invasive. Then you can go to the invasive ventilation as well, according to appropriately how best to address, so that you can stabilize the patient. So when you use the inotropes, so it's not routinely needed when the patient is having an adequate blood pressure. They are indicated when they have a signs of hypoperfusion, as I alluded earlier. The first and foremost, the most significant strong inotropic is the one noradrenaline, can go up to 1 millimeter mercury till desired blood pressure attained. The second, you may combine second inotrope is a dopamine, but you need to bear in mind the low dose dopamine have a renal arterial vasodilatation. The higher the dose, you have a more peripheral vasoconstriction. It is able to give you a more sustained blood pressure. The third agent is the dobutamine. The last is the adrenaline you may consider. Low dose dopamine, there is a renal dose we call because the improved renal flow, it promotes the diuresis. And combination of low dose dopamine and low dose furosemide actually more effective than the high dose furosemide. In certain cases, you may use that, right? The third, the next is a dobutamine. The dobutamine, you go up titrate gradually, where the dobutamine basically improves the cardiac output. However, we know the dobutamine does not reduce the capillary wave pressure. And that is in the precedent study example that it also tend to have a more tachycardia, also ventricular tachyarrhythmia problem. That's why we may not use dobutamine as a first, even the second line. We go for more of a third line in you want to improve the blood pressure. Okay, noradrenaline compared to the dopamine have almost equivalent. However, in the profound cardiogenic shock patient, norepinephrine or noradrenaline it works much better compared to the dopamine. The combination of noradrenaline with the dobutamine is safer as compared to you want to add the fourth line, which is adrenaline. So if you need to use noradrenaline after dopa, you can quite safely combine with the dobutamine rather than straight away go to the adrenaline. Then the third category is the warm and wet. Where in this particular category, the patient's blood pressure is not an issue. Systolic blood pressure is more than 100. However, patient is wet, right? Patient is having a congestion, feeling the lungs are full of fluid. At the same time, they also is having peripheral edema. So as the blood pressure is good, we can straight away address the wet lung with the IV diuretics. You may consider the two options. You may use a low dose diuretics. You may combine with vasodilators. Because the blood pressure not an issue, you can use IV nitrates. At the same time, you closely monitor the blood pressure. If the patient's improves is good, then you can later change to oral medication. If it's not improving, the systolic blood pressure is still good, you can change from the bolus to the continuous infusion of diuretics. You also may combine with thiazide. Then you have other options of using a low dose dopamine, for instance, to improve the perfusion to the kidney to improve the diuresis. So when you use the diuretic, as I told you, the bolus doses, you also can use the continuous infusion of diuretics that you can employ that, and you can also combine with thiazide diuretic. It has a synergistic effect. The low dose dopamine, where you have a 2 to 3 microgram per kilogram per minute, it have improved the renal perfusion and able to promote the diuresis. Of course, when they're hypotension, less than 100, you need to use the inotropic support there. How are you going to use the diuretics? Is obviously one, you use the bolus doses, you uptitrate accordingly. So the bolus doses, but if it's no further reduction, you can use the continuous. However, the continuous infusion, there is no advantages in terms of all-cause mortality, length of hospital stay, or the electrolyte disturbance. However, there's a few clinical trials, even the recent meta-analysis shows continuous infusion is superior in terms of diuretic effect, safety profile, and reduction in the BNP. And most importantly, you also need to address not just the how much volume reduction, you also need to weigh the patient daily, so that with the target, you need to have a 0.5 to 1 kilogram decrease in the body weight. More objectively, you need to assess. If you're having a weight reduction less than that, is either you are having an inadequate diuretic dose or the patient is having a diuretic resistance. This is one of the studies where it shows in terms of when you're using the bolus or the continuous infusion, all-cause mortality, length of hospital stay, not much different. But in this particular study, it shows no different. By another meta-analysis show that favors the continuous infusion in terms of reduction in the anti-pro-BNP. The last part is where you have a warm and dry patients. Where the warm and dry, this is why finally you wanted the patient with acute heart failure to go into the warm and dry group. They are not congested, and also the perfusion, they are adequate, which is systolic blood pressure is more than 100. In this group of patients, this is our target to achieve in acute heart failure, so that they can be discharged with their continuous oral medications. So finally, the key take-home messages. Number one, you need to evaluate the patients in terms of whether they are wet. Clinically, you assess them, look for pulmonary edema, do the JVP assessment, do the capillary refill time, hepatological reflux, lung crepitation, look for third, fourth heart sounds, look for all the signs of heart failure. Number two, obviously, you need to evaluate the, perfusion, whether the patient in the low output state, the shock, their cold peripheries, blood pressure is low, they're in the confusion, dizziness, the patient's low pulse pressure, now all the signs, or oliguria, all the signs of hypoperfusion. Then you look for whether the patient in the worst state, they have a combination of the both, and then you need to address how am I going to treat the patient. So as I alluded earlier, rapid recognition most important. You need to quickly identify what is the causality, do an ECG for instance, whether the patient have acute coronary syndrome, or patient having a valvular heart disease, where the patient having a arrhythmic component, a fast atrial fibrillation, where the patient is septic or anemic. All this, you need to identify the condition, address that, and obviously you need to quickly stabilize the patient and hemodynamic status. You need to decide where to put the patient. Does the patient need to go to the ICU or CCU example, or do you want to put the patient in high dependence? It depends on patient's hemodynamic status. Number third is the oxygenation is critical. That you need to assess the patient and then correct the oxygenation and the perfusion, and obviously relieve the clinical sign and symptom. And as I alluded, most important, need to identify the cause and need to treat accordingly. With that, thank you very much.
Thank you, Dr. Ali. I think we have time for a quick question and answer section. I think one of the common things that we actually have a lot of questions from our fellow and from our trainee is that about fluid restriction. Maybe I can call up Dr. Zalina to share his webcam. So the first question that actually coming from the audience is that what are we going to do, and what are the advice that we actually advise the patient on fluid restriction? And the question that was given to us is that do we actually have a magic number like a 500 cc, 800 cc, or 1 liter a day? So how do you deal with this kind of question? We all know that fluid restriction, when they do follow, patient may actually come in for hospitalization. Maybe I start with Dr. Sarina. So how do you decide what kind of volume?
First of all, when you assess the patient, you can know whether how bad is the lung is congested, and then from there we see whether it's a lower zone, mid zone, or up to full blown APO. Then if you after giving diuretics, patient still not responding much, not much of urine output, then probably we have to bring up the blood pressure, start a low dose of dopamine for the renal perfusion, and see whether that is going to help the patient to increase or improve the urine output.
No, I think the question is actually when they discharge. So, the patient is already more or less dry. And so how do you decide? 500, 800?
Okay. Because usually when I advise the patient, what usually we said is the water is about 500, and we also include about coffee or tea about twice a day, 100 cc. Possibly they might be taking soups or another 100 cc. So maximum is about 800 for a patient who is compliant to the fluid restriction and compliance to the medication. Unless they come with another failure or worsening of the edema, then we have to cut further to 500. And we also have to advise them about the salt intake.
Any practical tips, Dr. Ali? on this food restriction?
I think these are very practical questions, at the same time very difficult, because these are the things that when the patient is an outpatient, when you're seeing them, 3 to 4 months later, in between, it's one of the things that first of all, we can counsel them. At the same time, they are on diuretics, they feel more hunger, they keep waking up at night, they go into the toilet despite adjusting the time of the diuretics, and they're on confounded by the diabetic some more. So these are the things the patient tend to overload themselves. So that is a very tricky area. Despite we give the advice how much, we need to practically show them the bottle. 500 cc bottle, you take the 1 liter bottle, this someone you can take. And I tend to go by patients, how they respond. Let's say you put them on maximum therapy, they're more stable. I gently give them some leeway to increase to gently up to 1 liter or so. So I have to show them very practical. Otherwise, patient will be binge drinking in between. Right?
Yeah, just a quick question. Tol Waptan, do you have any experience, Dr. Ali?
No. I have no experience on the new class of that. Yeah. Not much comment on that, unfortunately.
No, me too. I haven't used it before. It's supposed to sort of to treat those who actually have a hyponatremia associated with SIADH. But I think the heart failure, I have to say that I have no experience at all. Last question, maybe I will ask Ali and Zarina at the same time. So if the patient have acute heart failure due to ST elevation and MI, do we do the diuresis first, or we bring to the PCI, Ali?
We should stabilize. I think it's in a STEMI situation. It is obviously when the patient go to acute heart failure, they are already going to KILIP 3. If they are shocked, they're going to KILIP 4. These are the things that primary PCI is quite established role. It all comes together. As far as you didn't address the myocardial stunting at that point in time, it won't have, the patient will easily deteriorate from the class KILIP 2, they go all the way down to KILIP 4. So in a STEMI cohort, you need to go aggressively to PCI. At the same time, you also have to, treat the other component, whether they're going into a hypotension, then you need to institute the, the inotropic subtort. Or sometimes in the cath lab, you also use the IABP as well.
Yeah, Zarina? Zarina, I think you're mute.
I do agree with Dr. Ali. We do have that kind of patient where patient presented with STEMI in APO. So usually what we do is we see the blood gases and immediately we intubate the patient, and we bring the patient to the cath lab and do the PCI and plus minus IABP, and also with the to aspirate the clot and stent, whatever it is needed. And then we also on the same time we started the inotropic support. Then later
I always worry. Yeah, I agree. I think I always worry about patient bringing down to the lab when actually in heart failure. My personal experience is that the moment I inject the first couple of mils or the contrast, somehow the patient will develop in a very bad acidosis and they will just collapse in front of you. So I think I agree with Zarina and Dr. Ali. I think in this situation where you're looking at KILIP 3 or 4, you better intubate the patient, make things a bit more controllable. So Ali, you have shared with us the warm, cold, dry, wet classification of heart failure. So the question is that whether it is applicable for non-cardiogenic pulmonary edema. I think one example I can think of would be, for example, a severe stroke, for example, that actually bring in with pulmonary edema. Does this still work?
I think this is a very reason that they come out with this classification, because the traditional classification based on the causality, you go for the cause and then you come up with what sort of heart failure, is it pulmonary, is it neurogenic edema, so but now the cause comes later on. You classify the patient based on the heart failure, you address the heart failure itself, then you look for concurrently, as I given the 5 principles, the cause, you try to address the cause. As far as the patient is a heart failure, BNP raised, you already established wet lung, for instance, you treat the heart failure as it is, with all the classes of the heart failure.
That's true.
Yeah, okay. I'll ask the last question, number 6, to Zarina. Now, when you actually have stabilized the patient, intubated and inotropic support, which guideline evidence-based medicine that can be continued. We are not talking about starting, we're talking about continue. And I would like to expand the question, not just looking at Coralin or Entresto. How about ACE inhibitor, beta blocker, and MRS spironolactone? So the situation is reduced ejection fraction, intubated inotropic support. Which one should we continue? ACE, beta blocker, MRA, Coralin, Entresto. What's
Very subjective.
I think this one is very subjective. We have to go according to the case-to-case basis. We also have to see what is the renal profile of the patient, the blood pressure, because and also the heart rate. If the patient's tachypnea, then probably beta blocker first, and we also have to see the creatinine level. Definitely, if the patient on AKI, we shouldn't start any ACE inhibitor or Entresto at that point of time. That's my opinion.
Ali,
And
any,
if I
any
add-
last comment?
Like if you look at the Coralin in the SHIFT trial, it's not in acute heart failure sort of treatment. It's more of a stable heart failure with reduced ejection fraction. If the heart rate is more than 75 or 70 or 75. So if you look at the clinical trial, it's never been in an acute sort of admission. So, and also I've seen some, they even throw Coralin for atrial fibrillation. So you need to be careful. It works, the IF current inhibitor is SA node. So it shouldn't be using for any arrhythmic component. You should be very clear. It's only used when the patient is stable. All right. In terms of Entresto, there are data that's in terms of pioneer study. You can use when the patient is stable before discharge. You may consider with it, but not at that point in time intubated with inotropic support, because it still brings down your blood pressure. So at that point in time, obviously, I follow the algorithm, stabilize the patient first. Once they are stable, then you may consider, before the patient home, you may add on the patient with appropriate all this, stabilizing drugs.
Yeah, I agree with Ali. I think if the patient is intubated or inotropic support, I think things change very, very fast. And you really want to have the kidney to shut down, blood pressure to drop further. So usually in my practice, if the patient actually requires inotropic support, whatever the patient has been previously on, whether it's an ACE, beta blocker, or Entresto, I will actually stop them temporarily until I can slowly wean off my inotropic support. Then I will reintroduce one. So this will be my suggestion. So I'd like to thank the speakers for the first session, Dr. Zarina and Dr. Ali. So we'll move on to the second session, and please continue to send in the question. So the second session, we are going to focus on the other problem that we usually see in heart failure, that is diuretic resistant. A patient came in with extremely fluid overload, you try diuretics, whether it's a Lasix infusion or furosemide boluses, and yet the patient still in fluid overload. So how are we going to deal with that? So to share with us, first speaker will be Dr. Satish Kumar Govindaraju. He is currently the consultant cardiologist in Manipal Hospital, Klang. He has been trained in Kajang, UKM, and lastly in Hospital Sedang. So he will share a case with us, how he managed a patient with diuretic resistance. And after that, Dr. Eva Rezan Abdul Rahman will come out and talk to us, what did the guidelines say, what are the data say about diuretic resistance. Dr. Eva currently is the consultant cardiologist in KBJ Damansara Specialist Hospital, and he's the current president of WHO or Women Heart Health Organization in NHAM, and he's also a fellow council member of NHAM. So she will sort of talk to us after Satish's presentation on diuretic resistance. So to start with, I'd like to invite Dr. Satish Kumar to share with us his case. Thank you.
Thank you.
Thank you very much, Prof. Chi, for the kind introduction. And thank you very much to our Novartis team for the opportunity. Okay, good evening, audience. And today I have a case which is not a very difficult case. It's quite a straightforward case where I come across a bit of diuretic resistance in this case. This case is about Mr. T, who is a 70-year-old Indian gentleman, was obese clinically, and he presented with his chief complaint was bilateral leg swelling for 2 weeks. Okay, and he is actually compliant to medications, but there was no resolution of the edema despite increasing his Lasix. So focusing on his leg swelling, it was persistent for last 2 years despite diuretic therapy. He has been taking diuretic therapy chronically, but it is always there. But this time is the worst ever. And then he wears, because of his chronic edema of the ankles, he wears a special type of sandal where it has a flap with Velcro. Even that he couldn't wear it because of this time the edema was super big, and he had difficulty in walking because of that. However, there was no pain or any redness in that, and also there was no fever. While I examined him, I saw there was a skin break in his left shin, with wetting his pants, covering the shin. There was clear fluid oozing from it. Okay, and however, he claimed there was no SOP address, but of course he had a significant reduction in effort tolerance. His NOHA around 2 to 3, and however, he still denied orthopnea and PND. He is also a chronic diabetic, type 2 diabetic patient. He is also hypertensive. He has dyslipidemia, and then he has CKD stage 3, and he had a right renal calculi about 7 years ago, and then after that there was no recurrence, and he's also a BPH patient on treatment. Previously, he was investigated because of his recurrent admission for his bilateral leg swelling. They did COROS twice in 2013 and in 2019, which only showed a mild CAD. There was no significant ischemic heart disease. And recently, during his visit, the previous cardiologist in my center, he diagnosed this patient to have a very high PVC burden of more than 13% and referred him to IJN. So this was somewhere around Deepavali, before Deepavali, if I'm not mistaken, where they did a electrophysiological study, and RFA was done at the junction between aortic root and left ventricle, and also posterior medial papillary muscle. And in the notes, it was written as a successful procedure. And however, the patient complained that it was very complicated. It took more than 4 hours, and patient was having a lot of shortness of breath and difficulty to pass urine. And because of that, subsequently, he had to be warded for a long period in IJN. This was the ECG before they did the EPS and RFA. So he developed hospital-acquired pneumonia in IJN, was subsequently warded for 11 days there, was given tazocine, augmentin for 10 days, and then he complains that ever since he came out of the ward there, he has been having giddiness, and then he's not feeling well, and then this edema has been going up. So, and also he was told to have a bit of low BP during the hospital stay in IJN, and they stopped his Cowsill for that. So he came to me with taking Sotalol 40 mg BD, Aturvas 13 20 mg on night, Lasix 40 mg BD, and he told me because of the edema, he has been taking 3 times a day also sometimes, but it didn't give him any relief. And he is also on finasteride, tazocine, and he also on subcut Lispro 14 unit TDS and Lantus 24 units on night, and also on pantoprazole for his gastritis. So while I saw him in the clinic. So in the clinic setting, his BP was slightly on the lowish side, or 98 over 60. Pulse rate was 56. SpO2 about 95, 96. He was afebrile. On examining his lungs, there was reduced entry bibasally. There was no obvious murmur. The heart sound was actually a bit muffled, and the abdomen was obese and soft. The JVP I could not assess because of his short neck and obesity. This is not his picture, but I wish I've taken the picture of his legs. It was really huge and was really pitting edema all the way up to even just above the knee as well. And when I checked his blood investigations, he had a bit of anemia. The HB was only 11.9, and platelet and total white was pretty normal. And he told me that he lost a bit of blood during the IJN EP study, and subsequently he was put on hematinics on discharge. And his renal function was not too bad. He was still having a grade 3 CKD. Creatinine was 1 to 2 with the eGFR of 53, and electrolytes were pretty normal. Okay, and his HbA1c was 7.4 and RBS was 5.5, and I was expecting his albumin to be low, and his albumin was normal as well. And on checking his BNP, the BNP was 1844, was raised. The CRP was normal, ruling out any systemic infection, and his LFT and thyroid function was normal as well. So this was the ECG done before his admission. So of course, compared to the previous ECG, we don't see the PVCs anymore. Probably it was a successful procedure. But if you remember that ECG, you can see that the complexes are a bit smaller. And on examining his chest X-ray, obviously we had bilateral cosophrenic angle blunting, and there was some septal lines, Calibi lines, and cardiomegaly. So this was the latest echo. Since this is a cash paying patients, we just had to quickly do a focused echo looking at his heart and ejection fraction. So I found that he had a significant pericardial effusion, which is about 1.2 cm in the anterior. In the this is the paraxis, long axis view, and short axis he also had about 1.75 cm of pericardial effusion. So I flipped through and then looked at his echo, which was done not too long ago in June. It said LV was dilated, but his systolic function is relatively good. There was no regional wall motion. His EF was 55 to 58, and the latest echo also confirmed that his EF was about 55. His LA was dilated. He had mild mitral valve stenosis with an MVA of 2.2 cm. He had some calcified valves and restricted mobility. Probably he had some chronic rheumatic heart disease. His RV was normal size and good function. The TAPSE was 2.1. Aortic valve also thickened. I had mild to moderate aortic stenosis. The valve area was about 1.5 cm. The right tricuspid valve had mild TR only. Then estimated systolic pressure was 27 only, and ruling out any severe pulmonary hypertension. His pulmonic valve was normal, and he had minimal pericardial effusion even back in June. Okay, this is the echo. All right. So obviously, considering his clinical signs and symptoms, which was consistent with heart failure, he had normal LV systolic function. And there was evidence of LV diastolic dysfunction. So I diagnosed him to have fluid overload secondary to heart failure with preserved ejection fractions. Or if I were to give a full diagnosis, it would be acute decompensated heart failure with preserved ejection fraction. So what I did was, in this case, initially, because of his lowish BP, I decided to cut down the medication that can cause further BP reduction, because obviously I'm going to give him a high dose of Lasix to improve his edema. So another thing that I did was, his RBS wasn't so bad, it was only 5.5. So I told him that I'm going to stop his pre-meal insulin. So I stopped it, and I had a gut feeling also saying that why not I just cut down the lentils and see, while admitted in the ward, I can observe his sugar. So I reduced the lentils to 12 units on night, and the rest of the medications I continued. So on the second day, when I observed him, his BP range, the overnight, was about 112 to 129, and diastolic was 53 to 70, which was not too bad. It was not as low as what I saw him in the clinic. And without the sotalol, the pulse rate remained in about 60 to 70. The saturation was good. But what I wasn't happy was with the IV Lasix of 60 mg TDS, which is about 180 mg per day. Okay, so I only achieved about 1.5 liters, considering that he was super edematous. So I was expecting a urine pouring out in the range of like 2.5 to 3 liters, or more than 3 liters, somewhere around that. But with that, I didn't achieve that. So I was quite confused why this patient is not achieving with such a high dose of Lasix. So is this diuretic resistance? So just before we go into what is diuretic resistance, I just want to know, check the audience if they know what is the definition of diuretic resistance. Is it a failure to achieve adequate diuresis despite repeated doses of furosemide of 80 mg? Or is it a failure to achieve adequate diuresis despite combination of diuretic therapy, like combining loop diuretic with thiazides or MRA? Or is it failure to achieve adequate diuresis despite using 240 mg of furosemide per day? Or is it failure to excrete 90 millimoles of sodium within 72 hours of 160 mg furosemide BD? So can we have a quick poll here? Audience, don't worry. I know this is a busy slide and the question is quite complex. Feel free to answer. No right and wrong answer, don't worry. Nobody is going to punish you. So are we running the poll now?
The poll
Yes,
is
we are.
now.
All right, almost the answers are very much divided among all the options given. So the real answer would be, actually I just took out all the options are actually correct, but there is no actual single consensus on a single definition of diuretic resistance. Actually, on general, we take it as failure to decongest despite adequate and escalating doses of diuretics. And going by the options just now, all of them are true actually. All right. So with that, I diagnosed this case to be a case of diuretic resistance because I gave him about 180 mg of Lasix per day, which is about almost 2.5 times of his what he was taking orally. So which is what generally what we do. So despite that, he didn't achieve. So this time, what I did was I increased the Lasix. I increased the Lasix dose, as well as I changed the method of giving. Instead of bolus, I started giving him IVI Lasix infusion. So also called as continuous infusion of loop diuretic therapy. All right. So just like what Dr. Ali mentioned just now, definitely this is superior compared to bolus doses. And another thing what I did was on the second day, I added Diavan 40 mg BD, it's a low dose, because this patient was previously on Coversil and we stopped Coversil for quite some time. He was not taking ACE or ARB, which would have caused the RAS system to react once I gave the bolus Lasix. So to prevent the post-diuretic sodium retention, I added Diavan for him and continued the rest of the medication. So this time around, he responded very well, where I got a very good response, about 2.9 liters of urine over 24 hours. And he had quite a significant of weight loss. If you see, from 105.6 kg when he came, now he was only weighing about 102.8, about 103. And this time around, his blood pressure also maintained, except for about 1 or 2 readings below 100, which is about 98 only. The rest of the time, it was pretty normal. So this time, looking at his glucometer, which was not really controlled or slightly on the higher side, so I decided to take an advantage of that. Before that, I did, because he was poured out quite a bit of urine, I did a RP, and his renal profile wasn't too bad. His potassium came down a bit, 3.6, but not too bad until I had to give him any supplemental potassium. His chloride also came down to 100. His urea slightly went up, and his creatinine slightly went up, with EGFR slightly worsening to 48, but it wasn't too bad. So this time, I cut down the Lasix infusion from 10 mg per hour to about 7.5 mg per hour. Continued the Diavan, and this time, what I did, I wanted to make use of that high glucose in his blood by adding a SGLT2 inhibitor. So I started him on TAP Zik Duo, 10 and 1000 mg. This is a combination of our dapagliflozin and also metformin to give him some extra osmotic diuresis. And that indeed worked, where this time, on the 4th day, I got one of the maximal urine output, which was 3.8 liters. All right, previously this patient was not intolerant to metformin or anything. I don't know why he wasn't put on metformin and only went on taking insulin. So this time I introduced metformin plus DAPA to him, and his dextrose stick wasn't so bad. So it was acceptable range, and his vital signs was still in the normal range. His BP was actually not too bad. So the next day, what I did, I knew that this my strategy is working. So this time around, I changed again from IVI Lasix to bolus Lasix, about 40 mg TDS. And this time I gave him, I changed the Diavone to Entresto 25 mg BD. Why 25 is that, one is that through my previous experiences, I always start the patient on 25 mg, especially those patients who have a tendency to have low BP and also to have a tendency to for kidney function to worsen. So that was again proven to be a very good move in this case, where over the next 2 days, day 5 and day 6, I had 3.9 liters of urine, and on day 6 I had another 2 liters of urine, and he had a significant weight loss. He came down to from 105, he almost lost about 10 kgs. So, and his testosterone was well controlled as well. And this is without him taking the pre-meal insulin at all. So I completely stopped the pre-meal insulin, and he's only on Lantus 12 units on night. So because he poured out quite a bit of urine, so I checked his renal function again to see any electrolyte imbalance, but it wasn't too bad. The potassium came down slightly to 3.4. Other than that, the rest of the results are fine. The creatinine did go up. I wasn't too worried about that. Most of the time, this kind of drop in EGFR is common to see with diuretic therapy, and also with whenever we add Entresto or SGLT2. That's mainly because these agents tend to relieve the glomerular hypertension and reduce the glomerular hyperfiltration that results in reduction in EGFR. So this was the actual picture. Since I was going to present, so I took his permission and took his picture. And this was the screen break, which was initially pouring out clear fluid, stopped pouring out any more fluid, and then we did a dressing to that. And there was still some residual edema, but trust me, this legs is far better than how he came. So he achieved a total negative balance of about 9,460 mils. Okay, and then he achieved a weight loss of about 10.1 kg. Okay, and before we discharged him, we repeated the echo, and you can see that effusion was very much reduced, the pericardial effusion. Of course, his pleural effusion disappeared too. Okay, and we know that from the time he admitted, it was from 1.2 cm in the anterior, came down to 0.8, and in the lateral wall from 1.75, it came down to 0.8 cm. And his ejection fraction was still maintained about 53%. And I discharged him with Lasix 40 mg OD, because since I started him on Entresto BD, so I was expecting a good diuresis with Entresto and Zik Duo as well, combined with Lasix. And I reintroduced the sotalol again, because his blood pressure was pretty much acceptable range in the ward throughout the admission, and the rest of his medication, and of course only Lantus, and there's no more pre-meal insulin for him. And during the discharge time, I talked to him elaborately about his diet and all. That was the time I found out also that this patient actually a vegetarian. So Indian vegetarians are generally, they take a lot of these papadums and pickles to make their food more palatable, I guess. So he was actually liberally taking a lot of papadums and pickles previously. So that could be also one of the cause for his worsening edema because of excessive dietary salt. So from this case, I have some take-home points. So given that volume expansion is the key pathogenesis for congestive heart failure, loop diuretics are among the cornerstones of treatments for heart failure, despite not having any mortality benefit in our randomized controlled trials. And initial loop diuretic dosing in patients hospitalized with heart failure and congestion should be about 2.5 times their outpatient dose, which is like in this patient, he was taking like 40 mg BD. So when we want to give an IV dose in inpatient, it should be 2.5 times, which is about 100 mg BD. So either we can give 100 mg IV, 100 BD, or we can divide the dose further into TDS doses. Okay, and subsequent doses of loop diuretic agents should be guided by clinical response to initial doses. For a sufficient dose of loop diuretic agent, urine output should measurably increase within 2 hours. And just like what was mentioned during the previous presentation, the continuous infusion is definitely superior to bolus doses of loop diuretics. And increases in serum creatinine, you can tolerate up to 45 micromole per liter during diuretic treatment are common. So clinical context is the key. So don't stop your diuretic treatment prematurely. Always consult with your nephrology colleagues or with your senior consultants. And this renal aldosterone angiotensin may be reflexively activated by acute administration of loop diuretics. So further increasing sodium and water retention and thus curtailing the effect of the loop diuresis. So be sure to add your ACE inhibitor or ARB to inhibit your RAS system. And excessive dietary sodium will offset the diuretic effect of loop diuretic. So besides advising patients on fluid, more importantly, we should focus on cutting down their dietary sodium, okay, which does more damage than the little bit of excessive fluid that they take. Okay. Anyway, with my experience, I think it's very difficult to control the fluids, but at least the dietary sodium, we can put a real emphasis on that. So with that, I thank you, and that's the end of my presentation.
Thank you, Satish. Nice tips on the papadum. And now I think I will pass the floor to Dr. Effa to sort of give us an overview and summary of diuretic resistance. Dr. Effa.
Thank you very much, Prof. Chi. So now I'm very aware that I am the last lecture here, and I'm very aware that I'm probably the one that's holding you back from bidding your 12/12 sale. But I promise I'll be real quick, and I hope you find the lecture very useful. Okay, right. Now, if you were to give a 40 milligram of intravenous furosemide in a normal individual, you would expect to get at least around 3,000 or even to 4,000 liters of urine in the next 6 hours. However, if you were to give the same dose in patients with heart failure, as the graph showed, that the efficiency of the diuretics is widespread, with a tendency to develop blunted response to the diuretics. Now, in patients with chronic heart failure, as demonstrated in the paradigm study, showed that the risk of hospitalization and death is about 20% at 1 year. But if the patient developed acute heart failure, the risk is high, even up to 60% at 1 year. And it's particularly high in patients who, at discharge, still have ongoing congestions as well as worsening renal function. Now, the term diuretic resistant has not been reliably defined, but there is a general theme of all the definitions that people try to propose, whereby there is a reduced or even loss of diuretics, which is water, as well as natriuretic response, which means sodium, despite adequate diuretic regime. And this entity is less likely to occur in patients with mild LV dysfunction, the ones who does not use chronic Lasix on daily basis, and the ones with a normal kidney function. Now, we know that there are several diuretics medications available. However, the cornerstone of treating patients with acute heart failure is the loop diuretics. Now, the loop diuretics acts at the ascending loop of Henle and is probably one of the most potent agents to induce diuresis as well as natriuresis. Hence, most of the guidelines recommend it as a first-line therapy, as a decongestive therapy. Now, another agent that sometimes people tend to use in combination with the loop diuretics is actually thiazide diuretics, which works at the different parts of the nephrons, which is the early distal convoluted tubule. Now, this is an old drug, which is the ethazolamide, that works actually at the glomerular apparatus that can induce a significant sodium excretion as well as water excretion. Now, I'm just going to compare the pharmacology of the most commonly used diuretics here in Malaysia, which is furosemide and bumetanide. So if you were to use as a benchmark furosemide of 40 milligram and with the bumetanide of 1 milligram. Now, the bioavailability of furosemide is very variable. It can spread between 10% to even 100% with a mean average of 50%. But the bioavailability of the bumetanide is a lot better, which ranges between 80 to 100%. The onset of the furosemide is also slower, particularly the ones that are derived from the tablet forms compared to the bumetanide. So if you were to also convert tablets to intravenous, for furosemide, you would require doubling the dose if you were to convert from the oral version to the intravenous version. But with the bumetanide, you can convert in a 1-to-1 ratio from a tablet to the injection form. Now, in order for diuresis to occur, it must fulfill these 4 little concepts. If you are giving the patients tablet form, the patients must be able to ingest and also pass through a good GI absorption. Then the blood pressure must be good enough to deliver the diuretics to the kidney, and the nephrons must work, and also the dose must be adequate for the diuretic drugs to be secreted into tubular lumen before being able to bind to the protein. Now, there are many causes of diuretic resistance. It can be categorized as pre-renal as well as the intrarenal. And you can see here there are arrays of mechanisms which can contribute to diuretic resistance. I would like to pick one in each of the category, which is for the pre-renal is the venous congestion. Now, as this graph shows that as your central venous pressure increases, not just the renal function tends to drop with increasing CVP, but also in terms of the diuretic as well as the natriuresis response. So this just shows that the role of the venous congestions is very important. So you would want to, if you have access, to measure the CVPs non-invasively. This is something that you would want to go for in patients with heart failure as one of the guiding factors in terms of decongestive therapy of your patients. Now, the next one I want to also highlight is the importance of delivering an adequate dose of the loop diuretics. Now, the loop diuretics has a pretty steep dose response curve. Now, it started off with pretty minimal effect. But once you reach the threshold whereby the diuretics are secreted into the tubules, then you actually get a very dramatic response of diuresis and natriuresis. After that, you reach to a ceiling level whereby doubling of the diuretic dose does not necessarily would increase the natriuresis as well as the diuresis. Now, this is what happened in normal population. Now, what about patients with heart failure? Now, patients with heart failure unfortunately have a slightly different curve. Their curve is more rightward in such a way that to achieve the same amount of diuresis, it requires a higher dose of the diuretics. And the ceiling is also being pushed down in such a way that the level of threshold, level of ceiling to get is actually very, very easy to achieve. The next one I want to also introduce is the concept of what we call diuretic braking. Now, this is our nephrons, and the ones that we always use most of the time as a first-line agent are the loop diuretics, which actually blocks the sodium from being absorbed, hence is being excreted. But in patients who use chronically the tablet forms of a furosemide, what happened was the body is used to the amount of the sodium being delivered to the distal tubule is very high, and as a result, the cells become hypertrophy, which can cause a compensatory sodium reabsorption, and this is what we call a diuretic braking, whereby initially you get a natriuresis, but because of the chronic usage of the furosemide, it can stimulate some alterations in the nephron, which causes the sodium to be reabsorbed, and hence the net clinical benefit is actually limited. Therefore, that what you find in patients with heart failure, to achieve an amount of diuresis as you would achieve in a normal population, you would require a higher dose to achieve the same amount of natriuresis and diuresis. So how would you judge whether the diuretics that you're giving to the patient is working? Now, the easiest is actually to measure the urine output. And what we want to aim is urine output is between at least about 100 mils per hour. Now, there is also a concept which I think is pretty relatively new to most of you, which actually using the spot urinary sodium to actually guide you in terms of your diuretic regime. Now, this urinary sodium is actually very useful in the first 2 days of decongestion therapy, where it can be used to predict how good is your patient responding to the current diuretic regime. Now, the next one is actually the weight change. Now, weight change is pretty cheap and it's mostly pretty easy to done, but unfortunately data have shown that the effect of weight change to the natriuresis and the diuresis is actually pretty variable and may not 100% reflect the total amount of diuresis that you will get on a patient. So how do we go about overcoming diuretic resistance should you encounter one in your clinical practice? Well, number one, you have to optimize the patient condition. Now, if the patient is hypotensive, okay, then you would want to correct the blood pressure by using inotropic support. Thereby, you know that the drugs that when you give them would actually arrive to the kidney. You also want to correct the hypoxia, either using with maybe nasal prong or face mask, or even with a non-invasive, sometimes with an invasive intubation and ventilation to ensure adequate oxygenation. Now, metabolic disturbance can occur quite commonly, especially in the ones who have abnormal kidney function. Now, sometimes what you need to actually correct some of the acidosis for the kidney to start working again. And also, you need to monitor closely the electrolytes like the sodium or or the potassium, which sometimes can go low or even high in patients whom you are treating with diuretics and has impaired GFR. And most of these patients, there's always something that tips them into decompensating. It can be infection, or it can be acute coronary syndrome, or it could be the anemia itself that can sometimes tip patient into the heart failure. And this is something that you also need to address. What is the precipitating illness? Another one, while patient in the ward, you also would want to fluid restrict a little bit in order to achieve a negative net. And low salt diet, although this is still open for debate, but you would probably want to achieve as much as natriuresis as you can by putting the patient on a low salt diet to get some of the negative net effect. It is also very important to avoid unnecessary renal toxic drugs. And when I say renal toxic drugs, these are the ones like the non-steroidals, NSAID drugs, because this can sometimes create a competitive binding with the diuretics, especially at the distal nephrons. And also, if the patient is also treating as an outpatient, you would want the patient to be compliant to not just with the fluid restriction as well as the low salt diet, but as well as with the rest of the medication. Now, our CPG, together with the ESC and the ACC/AHA guidelines, recommend loop diuretics as the first-line therapy in patients with acute heart failure. And the starting dose can be as little as 20 mg and even up to 600 milligram actually to be used per daily. But just be careful that if you were to cross the threshold of 300 milligram, the risk of ototoxicity is very high. It is also very important what we call the timing of the patients to receive diuretics. Now, the moment when the patient arrives in a hospital, you wouldn't want to delay the diuretics administration, as the longer the patient has to wait to receive the diuretics, the higher the probability of the in-hospital death. Now, the ESC actually proposed a position paper on the use of diuretic therapy in patients with heart failure. So this is something that I would probably want to walk you through the algorithm. So whenever you have a patient with congestive heart failure, if the patient has not been using loop diuretics on their daily basis, then you would probably want to start the patient with a dose of 20 or 40 milligram of intravenous furosemide. But if the patient is on regular furosemide tablet, then you may double up the amount of the diuretics furosemide given intravenously or during the first encounter at the emergency department. Now, after that, you need to evaluate the effect of the diuresis. Most of the diuretics actually works within the few hours, but then the level of the drugs starts to return to the baseline 6 hours later. So you would want to actually go back and reassess the patient within 6 hours of giving your first bolus of the IV furosemide. Now, if you're going to use urine output as your guide, if the patient pours more than 100 mils per hour of urine, then chances are you know that this patient is diuretic responsive. If you have the opportunity to do a sodium urinary spot, urine spot sodium, if the sodium is more than 50 in the urine, then it is also most likely that this patient is going to be diuretic responsive. Now, what happens afterwards, you have to listen to the lungs and you have to also assess what is the congestion level at that time. If the patient gets better and the congestion is also better, then you can actually repeat the same amount of dose and then reassess again about 24 hours later. However, if you find that the patient does not respond to the first dose, you may increase or double up the intravenous loop diuretics and then reassess again in the 6 hour and see where you are in terms of the diuretic response. Now, what happened on the second day? Now, if the patient does not if the patient is better, not as much as congested compared to the first day, and you manage to achieve a good urine output of at least 3 to 4 liters as a rough guide, then chances are you can continue with the current dose or even taper down. But if you think that this patient doesn't get any better, still congested, and the amount of urine that you get after the 2 boluses of the IV Lasix, then you want to reassess and see whether you can double up the diuretic dose to break the threshold. Now, what happened next will be guided by the patient's response. And if, say, for example, the amount of diuresis is still minimal, then you have few options, okay? Either you can do what we call a sequential blockage of the nephrons by combining it with other agents such as the thiazides and acetazolamide. But bearing in mind that if you're going to do this sequential blockage, the amount of metabolite disturbance like hypokalemia, hyponatremia is very high. and also patients might also get hypotension. Therefore, you really need to watch patients very carefully, and this is something that you probably want to do in an ICU setting rather than in the ward. Now, what you can do almost immediately, if you have been using intravenous furosemide, you can switch to intravenous bumetanide. Now, if you can remember the table that I showed you previously, it has better bioavailability and it's also faster working, and it might just be the one that you need to break the threshold. Now, should your method fail, this is when ultrafiltration comes in very handy. Now, ultrafiltration is something that we do not recommend as a first-line agent, but we do use it as a bailout therapy where after using a loop diuretics, you fail to get adequate diuresis. Now, one of the questions that we also get asked most of the time, would you use a bolus diuretics or a continuous infusion? Now, there's one randomized control trial that looked into this, and in this trial, they actually have 4 arms, which is they compare patients on intravenous bolus versus continuous versus high dose and versus low dose. Unfortunately, among these 4 arms, there's no significant difference in terms of the symptoms or change in the kidney function from baseline up to 72 hours. But they do know that patients with high dose strategy, they are more likely to get greater relief of dyspnea, fluid loss, weight loss with actually fewer serious adverse events. It is, however, the ones who receive high doses of diuretics are most likely to experience change in the renal function, but whatever change of renal function that they get at that time, it does not translate to a worse clinical outcomes. Now, what about diuresis and rising creatinine? Now, this is something that we see all the time in patients with chronic heart failure and impaired EGFR. Now, just as a guideline for you, what we mean by rising creatinine in response to the diuresis, that you actually get around roughly 25 millimoles per liter, or more than 25% increase in serum creatinine, or about 20-25% decrease in GFR. Now, the significant increase in the creatinine can occur in about 20-25% in patients with heart failure. But having said that, not all patients with acute heart failure would get a change in the creatinine. Sometimes the creatinine can even come down. Now, this is a study that looked at the trajectories of the renal function during acute heart failure. Now, what we see is actually the renal function is very unpredictable. You might get a decrease and then it comes down, or you might get, it might come down first and then it might increase slowly, or there's no change, or it can go all sorts of direction. But having said that, whatever trajectory of the renal function at that time in response to the decongestive therapy, it does not translate into the 180 days of mortality. What causes worsening kidney function with the use of diuretics? Well, there are multiple mechanisms. It could be at that time the CVP pressure is high, which can be reflective of the worsening of the heart failure disease itself. Or it could be that the patient is extracellularly volume still high, but intravascularly he has actually depleted. Or it could also be changes at the nephrons level, or whether or not it is a direct effect of the loop diuretics, we could not be sure 100%. So what happened when you encounter patients with worsening renal failure when you are in the middle of the decongestive therapy with the intravenous diuretics? Well, if the patient still demonstrate a good diuretic response, then you would want to titrate, either increasing, either maintaining with the same dose or decreasing the amount of diuretics based on the congestions. But if you have a poor diuretic response, then you have, unfortunately, go back to your fighting mat. Evaluate what will be the causes. Could it be because that the blood pressure is inadequate, that you need to use inotrope support to improve the blood pressure? And you also need to evaluate the congestions, whether it's actually worsening or pretty much hasn't changed. And then you would intensification of your diuretic therapy by either doubling the dose, or should the patient deteriorated, then you would want to go for the bailout strategy by using the ultrafiltration. Now, at all times, you would want to reevaluate your renal function and electrolytes almost on daily basis. So in summary, my take-home messages is diuretic resistance most of the time is because of the inadequate dose of the diuretics. And remember that the ones who are using furosemide tablet on daily basis, they would require higher doses whenever they decompensated. And you would want to reassess the diuretic response pretty quickly, preferably in the first 6 hours, in order to guide what is the dose of your next diuretic therapy. Now, you would expect a change in the serum creatinine in patients with heart failure. Now, that is expected, but it should not be the one as a breaking factor for you to down titrate your diuretic response. And I want you to always remember to treat the congestions rather than the creatinine. Of course, you have to keep an eye on the kidneys, but if you think that the change in the serum creatinine is not that bad and the patient is not acidotic, the perfusion is good, then you probably can continue with the same dose of a diuretic therapy until you decongest properly. And most importantly, if the patient is hemodynamically stable, you wouldn't want to stop other medications that serve as a neurohormonal blockade, like the ACE ARBs, your spironolactone. I mean, these are the ones that if you have a chance to continue, do continue them, because these are the ones who are actually disease-modifying drugs, not the loop diuretics, unless the patient develop hypotension or a severe electrolyte disturbance, then only you would want to interrupt. In that case, thank you very much.
Right. Thanks, Akbar, for the very nice summary of what do we mean with diuretic resistance and how are we going to tackle about it, and especially the final part, how are we going to sort of stand in the thin line between the creatinine is going up and patient is still having congestion. I think there's a few questions, but I think some of the questions Akbar and Satish have actually answered. So maybe the first question is actually about Satish's patient. Is there any reason why the patient is not on antiplatelet? Because I think the angiogram or CT scan actually shows mild CAD.
Yeah, and this patient, he was on antiplatelet previously, but after the IJN admission, they stopped it. And another thing is that we don't need it for primary prevention. So even I feel that it is not necessary actually in this patient because it's just mild CAD and we don't use antiplatelet for primary prevention.
Okay. I think if I had touched a little bit on the ultrafiltration in acute decompensated heart failure. So when will you actually call up your nephro colleague, and how receptive are they when you actually call them out? Look, I need an ultrafiltration, my furosemide doesn't work. So what is your experience and what are your encounters?
Okay, right. So the ultrafiltration does work, but you wouldn't want to use it as your first line agent. In fact, I think there is a study called the I think it's CARES heart failure study, which compares pharmacological therapy using loop diuretic and thiazides in comparison with ultrafiltration. Unfortunately, it's a negative result in terms of the mortality. In fact, the amount of diuresis and natriuresis you would get from pharmacology therapy is almost as good as ultrafiltration if the patient is still diuretic responsive, and it's actually with less side effects compared to ultrafiltration. But sometimes the creatinine just go up uncontrollably and the patients become more and more acidotic, and you think that the amount of the congestions that you are getting from your intravenous pharmacology therapy is not achieving, then you would want to call in your nephrology pretty early actually. Of course, the thing is, most of the time, by the time you come in, patients on inotropes, and then they come in and said, oh, okay, the blood pressure is pretty low. We can try with dialysis, but let's see what is the blood pressure first. It is important, though, to maintain a good amount of blood pressure during your decongestive therapy.
Yeah,
Okay.
I think you did very well.
So in Satish, what are your maximum dose of Lasix infusion in your practice?
So far, in my experience, I have used a maximum dose of 240 mg per day. So I have not gone
So that
more
will
than,
be 20 per hour.
yes, it's about, if I
Sorry, 10 per hour, sorry. Yeah.
10 mg per hour. And then if it is bolus, I'll give about 80 mg TDS. That's maximum I've gone so far. But literature says you can go up 220, if I'm not mistaken. How about you, Efa? What is your experience?
For me, I mean, the thing is, I mean, if you look at the guidelines, they actually allow you to go even up to 600 milligram. But that is something that I won't or I have not been able. I wouldn't want to go that far because of the risk of the ototoxicity as well. And the thing is, when you are at such a high dose already, and if you increase it even more, it doesn't give you the same amount of doubling of the diuretic response as you would go from 40 to 80 milligram. So for me, is if I'm going to use a continuous infusion, 10 milligrams per hour, or even up to 15 milligram if I needed to. But if I feel that it fails to reach the good amount of diuresis, this is when I would go with either a sequential blockade or the ultrafiltration route.
Yeah, Kevin, can we go to the second page? There's a question about, I mean, just a continuation of this question is that how long are you going to give the infusion before you decided that, look, should I increase or should I now give up and ask the renal team to come in? So, what is there a way to tell, like this question 5?
What I would do is normally in my clinical practice, I would go with maybe start with a 5 milligram per hour, or even up to 10 milligram per hour or so. And if the urine response is still poor, bearing in mind that you wouldn't want to wait the next day and see what happened next. Chances are, you would probably want to reassess maybe in the next 4 to 6 hours to see what is the response. Because at that time, by the time you leave it the next 24 hours, the creatinine would probably have gone up. The patient would have been acidotic. So this is something that I probably wouldn't want to leave that long before I reach out to my nephrologist. And plus, imagine if you have water in your lungs, it's not very comfortable at all, and patients can just tip into cardiorespiratory arrest very quickly if you leave them into APO for a long period of time.
Yeah,
Will you use albumin? Yes, Satish, will you use albumin?
Albumin, I have not used albumin combination so far, Prof. I have not much experience in doing that. How about you, Efa?
Unless patients have severe hypoalbuminemia, then I would probably consider. My experience with intravenous human albumin in this country, I've seen a lot of patients developing more fluid congestions with IV human albumin.
That's what I thought.
And I think it's probably because they use it too early when the albumin is not that bad.
Mm-hmm.
I will wait for the albumin at least drop to a single digit before I actually think about it. All right, I think we have a fantastic discussion on diuretic resistance today, and I think both Satish tell us how he managed, and I actually have given us a quick summary. So I think we have a good session and a lot of questions. In fact, I actually have filtered out a lot of other questions, so maybe we should bring this up in subsequent lectures and all that. So thanks everyone, and I will pass back to Wingzi from Novartis to take over to close the session.
Thank you, Prof. Chi.
Thank you very much, Prof. Chi, Dr. Ali, Dr. Effa, Dr. Satish, and Dr. Zarina for the very great sharing on all the cases and also the lectures on management of AHF and also diabetic resistance. And that's truly enlightening. And also thank you for addressing most of the questions as well. Definitely a very great session on that. So I think with that, to all the participants, this is actually the end of the sharing for today. And thank you for joining us and hope to see you again in our upcoming webinars. And have a nice weekend, everyone.
That will be next year. Bye, everyone.